This video is about the hidden inequities of the pandemic ED drop. We will examine why aggregate data marginalized patients during a health crisis and how to fix it. During the first wave of COVID-19 in the spring of 2020, emergency waiting rooms emptied out. We saw a 34% drop in total emergency visits and a 15% drop in hospital admissions. The question is, did people get healthier, or did the disruption simply hide a crisis of missed care? Our study examined 109 emergency departments and urgent care centers in Alberta, analyzing 1.15 million total visits. We compared Wave 1 COVID-19 data to the exact control period in 2019, stratifying the data by age, sex, geography, material deprivation, and First Nations status. The critical care crisis is represented by a 15% drop in life-threatening diagnoses. This includes significant decreases in cardiac conditions, self-harm, diabetes, and sepsis. The drop in these critical care categories indicates care that simply did not happen. The average patient, non-First Nations, male, adult, metropolitan, and not materially deprived, saw a decrease of nearly 80 ED visits and 7.7 fewer admissions per facility. This massive drop defined the overall pandemic narrative. But for marginalized demographics, this was not the universal experience. For First Nations communities, strict lockdowns and travel restrictions limited mobility. The lack of accessible primary care alternatives, due to limited telehealth and provider availability, meant the ED was the only safety net. This resulted in a smaller decline in ED visits and no statistical drop in hospital admissions overall. Women and other sexes experienced the caregiver burden. While total ED visits dropped similarly, admissions and critical care for women plummeted significantly lower. This suggests they disproportionately delayed necessary medical care due to increased domestic and caregiving responsibilities. Seniors maintained baseline ED visits for minor issues, but experienced profound reductions in hospital admissions. This dangerous gap suggests missed critical interventions, driven by both the patient's fear of hospital-acquired COVID-19 and provider reluctance to admit vulnerable patients. Geography reveals the metro advantage. Metro areas saw the maximum reduction in ED reliance by pivoting to virtual care. Remote and rural areas, further from urban centers, showed the smallest reductions, indicating a sticky ED reliance and inflexibility in accessing alternative care. This demographic divergence matrix summarizes our findings. Groups like First Nations and those in rural areas saw increases or smaller reductions in care metrics, while women and seniors saw significant drops in critical care, pointing to distinct drivers of care disruption. Missed ED presentations had a severe ripple effect. We observed more advanced stage cancers, higher rates of ectopic pregnancy rupture, and a statistically significant rise in mortality for chronic diseases like heart failure and diabetes. This was not a decrease in need, but a deferral of critical care. The data architecture has blind spots. Administrative data captures biological sex, missing gender inequities. Reliance on federal fee data miscategorizes First Nations identity. Crucially, there is zero routine collection of data regarding race, visible minority status, or disabilities. We cannot solve inequities we refuse to measure. We propose an equity-oriented care model. Instead of aggregate tracking that hides inequity, we need stratified demographic dashboards to allow for targeted resource allocation and equitable access. Real-time data architecture is a clinical intervention that must become standard. ED volumes have now rebounded past pre-pandemic levels. Current severe ED crowding is driven by staff shortages and lack of inpatient beds. We cannot solve this by treating the population as a monolith. Resource allocation must target the lack of primary care alternatives in marginalized communities. In summary, aggregate numbers hide systemic inequities. To build a resilient health system, we must fundamentally shift our focus to measure who is missing from the waiting room.